Great. Thank you, Mary. And good morning, everyone. Welcome to Grand Rounds. It's my pleasure to introduce Dr. Maisam Abu-El-Haija as today's speaker. She's a professor of pediatrics at the University of Cincinnati, a pediatric gastroenterologist, and the medical director of the Pancreas Care Center and the Islet Isolation Center at Cincinnati Children's, medical director of the Ohio, Kentucky National Pancreas Foundation chapter. She has a really great story about how she's taken, and you'll hear today, a really important disease condition and advanced it. She completed medical school in Jordan, pediatric residency and GI fellowship at the University of Iowa, and then joined Cincinnati Children's in 2012. She's an international authority in pancreatitis in children with 190 peer-reviewed publications, over 150 invited engagements. She leads the Pancreas Gene Panel, which is a high-throughput sequencing initiative aimed at precision medicine for patients with pancreatitis or evaluation. She's part of NIH-funded observational studies, or leads several of them, and is an integral member of a major consortium now renamed CPRC, for those who know it. And for today's Grand Rounds, Dr. Abu-El-Haija will tell us about crossing the Golden Gate, timely interventions and research in acute pancreatitis. I invite you to share your questions or comments during the Q&A section. If you're online, you can post it online just at the time that you have the question. And so please join me in welcoming Dr. Abu-El-Haija.
Good morning, everybody online and in the room. Thank you for taking time to listen for a story about a forgotten organ that sits behind the stomach. That's called the pancreas. Thank you, Sohail, for hosting me. Thanks for the wonderful Stanford team. Definitely not my first time to visit. A lot of the familiar faces again and seeing the great progress. Congrats for the GI and surgery programs at Stanford Children's for making the top 10 US News and World Report. So this is a great honor to be here celebrating with you all. I have no disclosures relevant to this talk, and my objectives that I will be covering today is really focus on what are the main elements for diagnosis and staging of acute pancreatitis, because it's not just one big bucket. There are certain elements that help you stage the disease and understand the management, and then determine the long-term sequela of acute pancreatitis. I met yesterday with the fellows and they asked me why and how I chose the field. If you are a curious person who is allowed and given the right tools to research a question, you would be a scientist. That's the definition of science. And when I was training in my fellowship, the patients were kept NPO when they have pancreatitis, but the patients were ready to eat. And the dogma was that you don't feed the pancreas and you let it rest. And when you question the dogma, you could do really great things. And that was kind of one of my starting stories. And then we also thought that pancreatitis is not a big deal. So what, you send them home and then they're fine. And today I will prove to you that that's not right. So how do we diagnose acute pancreatitis? It's really having 2 out of the 3 criteria, having the enzyme elevations, amylase and or lipase, 3 times the upper limit of normal, depending on the lab range that you utilize, having the symptoms that actually make you suspect pancreatitis, and it's usually the abdominal pain. It's not always classic epigastric radiating to the back. Keep in mind, when we're pediatrician, you could have a toddler who just have intolerance to feeds, or an infant just with fussiness, and then finding those on imaging could be edema, interstitial enlargement of the gland itself or surrounding tissue. So a study from the Stanford group here, actually, utilizing Truven Health and Market Scan as a commercial database, queried over 140 million unique patient records. And from an epidemiology standpoint, it showed that the incidence in children has stabilized over the years that we show here. And it's about 10 per 10,000, 10 per 100,000, but in adults, it might be decreasing from 120 to 111 per 100,000. More on from national studies, we here queried the PHIS database, which is the Pediatric Health Information System, which is a major 47 children's hospitals entering data. It's billing data, but what's nice about PHIS is that you can actually track the same patient over time within the same institution. So we looked at admissions that primary diagnosis was acute pancreatitis for that admission. And we've shown that over the decade between 2004 and 2014, that there is indeed a rising trend in acute pancreatitis across the country nationally. And this was, by the way, compared to all other pediatric admissions. So if you think about respiratory seasons and respiratory infections, acute pancreatitis was actually on the rise compared to those other common conditions. In the same paper, we go into the health economic impact of acute pancreatitis, because when you want to convince legislators and insurance companies, then these are kind of important numbers to have. And it does have a high impact. When you adjust for inflation over time, it's a more costly diagnosis. And that's probably because we have more tools in our toolbox, like better MRIs and ERCPs and other items that you can utilize. So as a schematic, how does pancreatitis happen? Usually we think that there's an acinar, which, the pancreas as the exocrine compartment is acinar and ductal cells. An injury takes effect, and that leads to alterations in calcium signaling is one of the ones. And then there would be zymogen, which are the pancreas enzymes activation, that then leads to inflammation that could stay within the gland or really surpass that to go to surrounding structures and cause tissue acidosis and hypoxia, then cell death and necrosis. But then even after the recovery, there could be late manifestations and late islet failure. So what do we know about management of acute pancreatitis? I will start with some of the adult landmark studies, but then walk you through the pediatric counterpart of these studies. So in terms of nutrition, this meta-analysis compared the total parenteral nutrition versus enteral nutrition for acute pancreatitis, the ones that are predicted to be severe. And here they had in the EN arm versus the PN arm, around 180 and 190 for each. And it did show that in terms of the meta-analysis and the forest plot, if you see for the trainees, the diamond is really where you have the pooled analysis and the direction of the diamond. If it doesn't cross the middle line, then it's a significant effect. It did show that the total enteral nutrition is associated with lower mortality. It also showed that in terms of organ failure, and the most common 3 organs that are affected in the pancreas, acute pancreatitis, that you have to watch for are the lungs, the heart, and the kidneys. And they're very much an open field for people to study these in children and adults. So the enteral nutrition has been shown to show favorable outcomes in terms of organ failure in these studies compared to the parenteral nutrition. They also carried on to look at infection rates, so there was lower infections and also lower surgical interventions in the groups that received enteral nutrition versus parenteral, which is great. Now we don't have to think about parenteral nutrition for acute pancreatitis. This study is a very simple in design study where they had 60 adult patients. It was probably one of the first to really test, can you feed a patient with pancreatitis? And they randomized 60 patients to allowed them to eat versus you need to be MPO. So they had 30-30. And what the study showed is that you really have no difference in abdominal pain if you feed the patient or you don't feed the patient. And the length of stay, as you may imagine, was lower in the group that was allowed to eat. So a good challenge for us to say you can feed the pancreas as a proof of concept. What do we know about IV fluids in terms of management? And we all know it's the cornerstone of therapy right now because we don't have much in our toolbox to offer these patients. This meta-analysis that had randomized controlled trials for using lactated ringer versus normal saline in all the available literature at the time that this study was conducted, looked at cohorts, and these RCTs are not present at that time in children, or were not present in children. So again, with the concept of pooled meta-analysis, it was shown that the lactated ringer versus normal saline had beneficial effects in terms of moderately severe and severe pancreatitis in A, and the rate of ICU admission, as I show in B, or the local pancreatic complications such as necrosis, fluid collections, and also the length of hospital stay. The waterfall trial was published in New England Journal of Medicine about 2 years ago, and it was a multi-center study, international, that randomized patients to either receiving what this adult group called aggressive versus moderate fluid resuscitation. And this waterfall trial, because they wanted to standardize at least the type of fluid, which is the way to do it, they used LR only. So their aggressive resuscitation fluid received 20 ml per kilo bolus and then followed by 3 ml per kilo per hour infusion. And the moderate resuscitation, they looked at the patient and they said, you're okay, I'm not gonna give you a bolus. You're not okay, I'm gonna give you a 10 ml per kilo bolus. And then they gave a 1.5 ml per kilo per hour. At the interim analysis, when they had 240 patients out of the targeted 770, the study had to be halted because there was a harm in using the aggressive IV fluid rate. And it showed that the higher rate was associated with more morbidity and even, and mostly it was kind of related to pulmonary edema or even death. When we think about which patients could be at more risk to progress to severe pancreatitis, you can't always do that by just looking at the patient. And there are different efforts to do that. So in the adult studies, maybe we studied them in medical school, there is the Apache score, the bedside activity index, which is BICEP score, Glasgow, Ranson. I'm not gonna go in detail of these because all of them fall short in terms of accuracy or even replicability, even in the same adult cohorts. But also keep in mind that these are not generalizable to children because age is a factor of many of them. And also because acute pancreatitis in children have a different risk profile than the adults. So in adults, alcohol and gallstones are thought of as the major drivers of acute pancreatitis episodes. Where in children, we really looked at this systematically over the years. And it started with a study led by Dr. Hussein from his times at Yale over 10 years ago. And it showed that medications are heavily implicated in acute pancreatitis in children. And then I partnered with him through the observational cohort study design at Cincinnati. And here we queried the patients that were collected over the years and found that drug-induced pancreatitis was the leading cause of all known causes of acute pancreatitis in children. So by itself was in 14% of the cases, and in other 10% was associated with other factors. What other things should you think about when you're managing a patient? You look for viral, systemic etiologies, toxic, metabolic conditions. Trauma is more commonly found in children than adults in general. And then biliary and gallstones are in the rise, especially in the rising epidemic of obesity, then obstructive factors. And don't forget genetics, but also we don't screen for genetics from a first episode. In fact, the guidelines say if you want to think about genetics, you really do it from a first episode only if you have a first-degree relative known to have a history of pancreatitis. And then in the same publication, we utilized the Bedalov system for classification. And we show here the number of cases that were associated with each drug. And class 1 is kind of a more definite, and it goes down in terms of the association and certainty to class 2, 3, and 4. So the drug-induced pancreatic injury cases, DIPI, in this cohort were 40 compared to no drugs implicated in the cases up to 125. And what was shown in terms of differences in presentations between both is that DIPI has a more severe course involvement, more ICU involvement, and a longer hospital stay. And one may say, well, maybe that's because it has comorbid conditions that could be associated with it. But also mechanistically, we don't know if it actually is a more aggressive course. And this is something we are still in the pipeline working on right now. So fingers crossed that the well-scored grant would answer some of these on an acinar and cellular level. So what do we know about studies in children in terms of the items that are covered, and mainly for nutrition and fluids? From my early days at Cincinnati Children's when I joined, I really wanted to understand the practice. I really wanted to do no harm and just start looking and collecting cases without proposing interventions. And sometimes the retrospective or observational studies are really the way to lead you into thinking later on into the interventions through research. So this is an observational cohort design just from a nutrition database. This is not part of the acute pancreatitis registry. In fact, this was an NPs and dietitian-led study, and they loved that. They wanted to do research, so they were collecting this data and recording what the patient ate with acute pancreatitis every single day. And what we showed as a group of concept is that the groups that were allowed to eat or receive enteral feeds if they had an existing G-tube were really having similar pain scores to the groups that were kept MPO. So that was encouraging. At least we could, without randomizing, just say, could you self-regulate and see? And actually they eat when they feel fine. And also the fat intake, grams per kilo per day, because we say, please follow a low-fat diet. That has no evidence for acute pancreatitis. Besides, if you have a biliary component or hypertriglyceridemic pancreatitis. We just say follow a general diet per age. And as they felt better, they were eating more fat, and the higher fat intake had lower pain intensity scores. In terms of the IV fluids, because they are an integral part of the management, and it's really that ischemia that happens for the pancreas. So the resuscitation, we have, like the Golden Gate, there's a golden window that you catch the patient and you need to give them the appropriate amount of fluids to reverse the cause and the injury. So the optimal component, the timing, the volume, the type, all of these questions are still remaining to be answered. So utilizing the Pediatric Health Information System database, we started querying this from available public resource data. And we had 1,500 admissions. Some used LR only for the first 48 hours, and some used NS only for 48 hours. We excluded all the cases that had combinations. And we showed that in the LR group, there was a lower length of stay in general when acute pancreatitis patients were managed. There was a lower infection rate, lower TPN, lower cost of admission. All of these big data or billing associated studies are important, but they're not confirmatory, and they can't confirm causation, but at the same time, they can help you start generating hypotheses. I had the pleasure to mentor Dr. Peter Farrell as I recruited him. He was a chief resident at Children's National and Children's Hospital of King's Daughter. He had started a randomized control trial in his residency. So you could do a lot as a trainee. And when we recruited him to Cincinnati, we helped him finish the study, and Cincinnati became the primary site. So we had thought of randomizing the patients with acute pancreatitis to either LR or normal saline. He fixed the rate to 1.5 maintenance, and his primary outcomes when he powered the study was CRP at 24, CRP at 48 hours, and secondary outcomes were length of stay and the severity of the disease. And the study had 38 in each arm, and it actually had to be stopped due to COVID, but he had powers for 40 in each, so we thought it's okay and safe to stop. And the CRP at 24 and 48 hours was not different between both groups. When we looked at the length of stay, the LR group is the bars in blue, and the NS are the bars in red. And as I show here, the histogram is for all the patients, each patient and their length of stay. And when you compare that histogram by the kernel density plots between both groups, there was no statistical difference between them. However, when you look at the rate of discharge within the first 72 hours, the LR group were discharged faster than the NS group. So they were recovering and getting discharged faster. And it's a reasonable way to think about measuring that intervention outcome, because your intervention is the first day and you're looking at the impact of the intervention immediately after. So at least that was promising, but still it didn't show that we could decrease severity from this sample size. So in terms of pediatric data, what do we do now? If I have a patient today in the emergency room, we can't just extrapolate from adult guidelines. Remember, I showed you that aggressive fluid in adults was associated with more perils or severe outcomes. And because we have differing weight-based formulas, the Holiday-Seeger method, you give more fluids for a body surface area, right? So you can't just apply the adult lessons. So how does that waterfall study inform our management? Again, because we had the observational cohort study of acute pancreatitis, and we collect over 200 data points of admission of every case that consents to be enrolled. And we follow these patients throughout the hospitalization and onward, even after discharge. And IV fluids, we meticulously jot those down, including the bolus, the type, the rate, and how long they continued. So we had a CAPER fellow rotating with us, Nick Norris from Dallas, for 2 months. And he wanted to do research. We said, this is the database. So he actually led this study and showed that if you look at the waterfall plot, the triangles is the higher curve, which is the aggressive fluid in that trial. And then you have the moderate arm is the one that has the small squares. So when we call for high fluids in pediatrics, it's really at the moderate rate in the adult arm, which is 1.5 to 2 times maintenance. You really are capping them at that. And this is another way to look at the outcomes. The green bars show the high rate. And remember, high rate in children is not the aggressive rate in waterfall study. It's 1.5 to 2 times maintenance, which equates to the moderate rate in the adult cohort. And I say that because it's confusing to many, but yes, you're using 1.5 to 2 times maintenance. That's higher than the rate you give a maintenance for a child. And that's in the green. And whether used LR or an S, really you had lower rates of moderately severe or severe pancreatitis in that cohort. Now, albeit this is observational, this is not randomized, so we really need to do more. And why do lactated ringers show promise? From a physiology standpoint, they are less acidic, they are an energy substrate, they're anti-inflammatory, and lactate, by acting on that G receptor, G protein receptor 81, do block the inflammasome activation. Also, it does block the activation of damage-associated molecular pattern, the DAMPs proteins. So it does hold promise, at least from a physiology standpoint. So where do we stand today? The jury is still out. There are no negative outcomes, at least for now, I can tell you, by using LR in our RCT. Also, it's reasonable to consider it for the first 48 to 72 hours. And the 1.5 to 2 times maintenance seems to be an adequate rate to use, at least at a starting point, until we have more studies. But we are actively designing a 7-center RCT, because when we powered the effect size, we need 750 patients. And Stanford is one of the children's hospitals that are invited to be in that study. So all of these address kind of sequela of pancreatitis, but if you think about the pharmacotherapy, you really have to address the root and the pathogenesis of the disease. And there are many studies that look at different targets. And I highlight in this table from Dr. Fred Gorlick and his team at Yale that some of the common pathways that you can think of as a low-hanging fruit, without minimizing that every pathway could take decades of study. Calcium is, for instance, one of the pathways that you could target. And here's a schematic, and excuse me if it's busy, but it's very, very important that we think about at a cellular level. How do we understand, how can we drive it to therapies? So this globe is the acinar cells. And within the acinar cell, if you have increased calcium production, like a hypercalcemia condition, that is a risk for pancreatitis. But then when you think about applying therapies, all the channels that had to do with calcium entry, just as we can simplify in this cartoon, and then in red are the different drugs that could target that and block it, could be potential therapies. And all of these are being tested, whether it's in animal models or cellular models. Then you have agents that help with the calcium extrusion from the cell. So if you get the calcium out of the cell, then you lower the intracellular calcium. That also could be helpful, like insulin or renalase. And renalase is one of the factors we started working on in acute and chronic pancreatitis with the nephrology team at Yale as well. And it really shows promise. And then there is a calcium intracellularly that could also lead to the activation of calcineurin, which is, or the higher presence of calcineurin, which is a calcium activated phosphate, and maybe blocking that could hold promise for the future. And here I quote some of the important papers, and I don't give it enough justice because Dr. Hussein has been working on this for really over a decade. So kudos to people like him for really changing the paradigm of how we think about this from the root of the disease. So they start with animal models showing that you could actually prove that calcineurin is important in the implication of disease. Then that blocking calcineurin could lead to dampening the severity or even stopping the disease. And then they go on to show that the local effect of that calcineurin is what drives the disease. So you actually have to deliver the drug intraductal rather than just give it orally, for instance. And from there are promised that they actually designed a randomized controlled trial to look at the effect of that by using tacrolimus, which is a commonly used medication for transplant, but it's a calcineurin inhibitor. So really randomizing the patients who are getting ERCPs, because ERCP is a risk for pancreatitis, into receiving indomethacin, which is a standard therapy, or tacrolimus, or a combination. More to come on that, because my understanding that you're still recruiting for that trial. Okay. From a society standpoint, we have more interest now in the pancreatic disease, thanks to the vocal people who want to put pancreas within the word North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. We don't have the word pancreas in there, so hopefully we would. We partnered with the Society for Pediatric Radiology because imaging has a big role in pancreatitis. I have the pleasure of working with Dr. Andrew Trout, and we meet every week to really think about more studies together. So this paper says any first timer, you get an ultrasound. If you don't see the pancreatitis on the ultrasound, please think of a cross-sectional imaging if you need to prove pancreatitis. Also, ultrasound is the first line because it does rule out gallstones. And then if you have complications, you would think about a contrast-enhanced CT or an MRI. And that it's usually if the patient doesn't turn the corner within the first couple of days. And then MRI, specifically MRCP, is reserved for acute, recurrent, and chronic pancreatitis to really visualize better the ductal anatomy. This is a big paper and a big table. I just want you to know that it exists. So you could come through a question when you're managing your patient. Do I use antibiotics, which are not indicated unless you have evidence of infection? But then you want to know which antibiotics. If a family asks you about probiotics, this hopefully would serve as a one-stop place summarizing the evidence in the literature for how you could manage acute pancreatitis in children. And how do we classify acute pancreatitis in children? We partnered with the adult colleagues who established the Atlanta classification guidelines and asked them, how did you do this exercise? And we applied pediatric-specific systemic inflammatory response and organ failure criteria. So in essence, if you have a patient, and that is really to your far right, with no complications, then this is mild acute pancreatitis. If you have a patient with exacerbation of a comorbid condition, so let's say they have chronic kidney disease and they come in and they get renal failure, this is a moderately severe acute pancreatitis. But also if they develop local pancreatic complications like necrosis, that's moderately severe. And the organ dysfunction lasting less than 48 hours puts them in the moderately severe. And if it lasts longer than 48 hours, then it is severe. And it does happen in children. If you look at studies, it's up to 15 to 30%, depending on the source you find. The image here shows on your left the same patient. The red area is pancreatic and peripancreatic necrosis that then advanced a few years later in the same child. This child had increased morbidity over another child that doesn't have those manifestations on imaging. Some of the knowledge gaps at the time when we started probing this question were that most studies were single-centered, small in size, and retrospective in nature. So I had the honor to really design the first ever observational cohort study in acute pancreatitis in children that became a source, an open source for people to come and ask questions, not only clinically, but even utilize some of the existing biosamples for future research, which then could help you develop prediction tools for severity and even who could develop acute recurrent pancreatitis. But more so, I became more focused on the long-term complications from a single episode. This is the design of the registry where we enroll at the index admission, and then we follow the patients at 3 months and 12 months. We collect laboratory measures, mostly to screen for nutritional data, exocrine and endocrine dysfunction. And we paired it nicely with samples that could really serve for biomarker discovery from plasma imaging and urine, as well as patient-reported outcomes, stool for future microbiome studies, and genetics and transcriptomics. One of the early studies done by Dr. Vitali in his fellowship was querying just the initial clinical labs on admission. Could you develop a severity prediction model? And then it was validated in 2 other centers on the East Coast. And it showed that a rising BUN on admission has a very good prediction to develop severe acute pancreatitis, but also paired with low albumin. So high BUN, low albumin had an area under the receiver operating curve of 0.83 for the prediction of severe acute pancreatitis. Then in terms of studies that could look into immune signals that could help you understand the pathophysiology of the disease or even serve as markers for severity, I partnered with Aida Habtizian when she was here prior. Also, she had Elena Jones in her lab, and we looked at mild and severe and healthy controls, and we utilized at that time the Luminex platform to screen for 76 chemokines and cytokines. So what we've shown is that in the group that developed severe compared to the group that developed mild, that interleukin-6 was elevated on admission. The same applied for monocyte chemotactin protein 1 or CCL2, and MCP1 and IL-6 do have potentials not only for understanding the mechanisms of the disease, but even for possibly targeted therapies. What do we know about endoscopic therapy? It does get implicated in acute pancreatitis, but really for specific indications. So it is if you have a gallstone disease, mostly if you are suspecting a common bile duct stone or if you see it. And then if there are pancreatic duct leak or disruption, such as in traumatic pancreatitis, or if you have complications such as pseudocyst or walled-off necrosis. But what is after a first episode? When it resolved, sometimes the patients are really anxious. And what do you tell them? If you bring them to clinic, what is the anticipatory guidance that you give them? So as we see, the pancreas is a rich organ where the endocrine cells, which is the globe of the islets, lives close to the exocrine compartment, which are the ductal and acinar cells. And there is now evidence that the exocrine disease, pancreatitis, could affect endocrine function, also quality of life, even recurrence of the first episode. So some of the studies from an observational cohort design, when we looked at patients and we followed them a year out after a single episode, we were surprised to see that these patients continue to have symptoms, abdominal pain, weight loss, diarrhea, and vomiting in up to a half of the cohort. They also had decreased quality of life by standardized measures by PedsQL, the generic score, as well as the GI worry scale. And we partnered with Jim Varney, the inventor of the PedsQL, because he had legacy samples on thousands and thousands of healthy controls. And really from a single episode, those acute pancreatitis fare poorly compared to healthy controls. And the GI symptoms were prevalent in both the ones who had recurrence and the ones who didn't have recurrence. In terms of nutritional abnormalities after a single episode, I also had the pleasure of mentoring Dr. Sarah Orkin, who went on after pancreatology research to do nutritional fellowship, but then still as an attending wanted to work on nutrition and pancreas. So that's the beauty of grooming the next generation of scientists and clinicians. So we have the 3 months and 12 months labs, as I showed you, for follow-ups. And she was highly interested in looking at nutritional markers after a single episode of acute pancreatitis. And what I show here is one snapshot from that paper, but at 3 months and 12 months, if you look at vitamin A, vitamin E, vitamin D levels, INR as a measure of vitamin K, so these are the fat-soluble vitamins, hemoglobin, even iron, they had issues in about a third of the patients at any time point. We don't know why. These are not patients who are clearly coming with weight loss. They're not clearly coming and saying, I have anemia. So unless you screen for it, you really would not find it. In terms of epidemiology, at first episode, we said it's 1 per 10,000, but a third of them would have a second episode. And we've also shown that the majority that recurs over 80%, they recur within the first 5 months. So very important to follow that patient after a single episode. In fact, we see all the patients up to a year after one episode of pancreatitis, and we standardize that across the board in our division. And any attending who doesn't want to or doesn't have the bandwidth, I say send them to my clinic. And everybody's very collaborative. They're like, okay, because you know what you're going to screen for. Chronic pancreatitis happens in about 2 per 100,000. But because chronic pancreatitis is mostly based on late markers of the disease, like calcifications and duct and strictures, the research will really benefit from that continuum and having markers, biomarkers of early disease. So what is chronic pancreatitis? Chronic pancreatitis is when you have imaging findings of that like bad looking pancreas that's full of stones and ducts and strictures with one of the following, either pain consistent with it or exocrine or endocrine dysfunction. But why do patients move to recurrent and chronic pancreatitis? And really the drivers are the germline mutations they hold. So the genetics of pancreatitis have expanded over the last decades in our understanding. There are trypsin-dependent pathways such as PRSS1 and chymotrypsin receptor C or SPINK1, or misfolding pathways or ductal pathways as the known CFTR gene that could drive it. At Cincinnati Children's, I had the pleasure to design a gene high throughput panel with including those genes in one chip, if you want to say. And it is a next generation sequencing platform that later on became CLIA certified to be a clinical test. But then we could use some of this data to really apply to research. So here in the research, I had a group of 120, half of them progressed to second episodes and half of them did not. But actually screening for those 10 genes, we showed that having 2 genes had a faster progression to chronic pancreatitis compared to 1 gene compared to none. We also showed that the progression to chronic pancreatitis as the red line by having a CFTR mutation or SPINK1 or PRSS1 had different rates to progress to CP. And when we looked at these genes that are pancreatitis risk genes and tried to predict who's going to develop diabetes later, we were able to derive some important modeling data from that. And for this, we had 17% of the cohort that we followed, 114 patients, developed either pre-DM or DM at 12 months. And this is a very busy oncoprint, but the square that I put is the pre-DM and DM group. And they had more variants implicated from those 10 genes compared to the group that didn't have pre-DM or DM after a single episode pancreatitis. And this complex way of looking at gene score, the 4 genes that were implicated were CTRC, SBDS, UBR1, and CFTR. So we actually derived an odds ratio of 5 by having the gene and a 5 by having severe acute pancreatitis, and then the combinations is higher to really develop diabetes after a single episode. Some of the exciting research in terms of post-acute pancreatitis diabetes is my work with Anna Gloin and a member in her lab, Lu Zhang. And we really are examining now in acute pancreatitis, what are the T1D, type 1 diabetes and type 2 diabetes genetic risk scores. And there does seem to be a separation if you have a single episode acute pancreatitis to develop diabetes after. Also, obesity was significantly different in terms of having a burden for the type 2 genetic risk score. And comparing it with the general population, and here we had utilized the UK Biobank. If you see at any threshold, the expected proportion of a certain GRS, genetic risk score, is mentioned, the observed proportion in our pancreatitis cohort is higher. That's whether they developed diabetes or not. And what does that mean? You keep collecting data and then you end up with big matrices. This is where one of the ideas we said, okay, we have clinical metadata, we have chemokines and cytokines, we have radiomics data, and then we have follow-up data. What do you do with it? And there's a lot that you could do when you have big data. And I understand this is huge in terms of machine learning also with the group here. But when we ended up with who develops diabetes at 3 months and 12 months and trying to develop these prediction models, we derived some clinical models at the end. So for instance, the one I show on the left, severe acute pancreatitis, IL-6 elevation, CRP with patient age were predictors of diabetes compared to the others. And then if you add subcutaneous fat to the model, also was a predictor to develop diabetes. And microbiome has a role. We still don't fully understand it, but this just gives you a flavor that you really could explore differences and actually mechanisms of disease by focusing from this angle. And these are not the genomics factor, these are environmental factors, so host, environment, interactions. So by shutdown metagenomics, we saw that there are differences in the microbiome structure by the heat map that I show here between acute pancreatitis and healthy controls. We also have shown that you could separate the mild and the severe group by their microbiome status. This is a PCA looking at beta diversity and the separation. And then you actually could find the species that are involved and later on develop pathway analysis to understand what you could target. So the E. coli and the Clostridium citrinae, for instance, were kind of the top hitters in the severe, and that does resemble the IBD severe acute pancreatitis, the IBD severe forms. And what happens over time to the microbiome? When you look at the Shannon diversity, the wider it is, the better, because that shows more diversity. But as you see here, the baseline on 3 months and 12 months, we compared them to the healthy control. They were really not different. So this paper shows that the dysbiosis persists after acute pancreatitis. And we show the same by the PCOA analysis. But what you could do is you could study the microbiome from a baseline and have it help predict who is going to develop certain outcomes. And this is a busy slide, but the A is baseline microbiome analysis. It did separate the groups that go on later to develop recurrent pancreatitis, which I believe this is very important if you want to target interventions for a disease progression. It did separate in diabetes. It did not show statistical significance, though. It did separate with GI symptomatology later. The groups that had 0 symptoms from 2 symptoms for more than 2 symptoms. And these are, by the way, all baseline. Like at the baseline episode, you could see some of those. So this summarizes what we talked about in one slide. Risk factors for acute pancreatitis: think gallstones, trauma, medication, systemic illness, genetics, metabolic. Incidence is 1 per 10,000. There's severity in 15 to 34%. And what is after the first episode? Decreased quality of life, prediabetes, diabetes, nutritional problems, and of course, recurrent or chronic pancreatitis. So to conclude, it does carry significant health alterations, and a subset would progress to severe diabetes or lower quality of life. And we could utilize genetic risk to study progression to chronic pancreatitis, but also to diabetes. And dysbiosis seems to be playing a role, and also watch for these nutritional deficiencies. So hopefully I convinced you that acute pancreatitis is not just a simple attack like we used to think, and it does warrant more attention from all of us. So by that, I conclude first by thanking the patients and really for their partnership. And they give to research not expecting any return because they're very grateful that there are interest in their disease condition. I thank my wonderful team at Cincinnati Children's that they work tirelessly for the sake of the patients, whether it's surgical or just kind of on the ward, and the funding agencies, of course, for funding our work. Thank you. Happy to take questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.